Hello everyone. So this is my case review for Advanced Practice Field Education 2. Okay, the agenda for this PowerPoint is the introduction, about the client, the history of the problem, the presenting problems, the client-intern relationship, knowledge utilization and intervention plan, and then further discussion. My internship is with Highland Community Services, and this is the mission for Highlands. HCS is committed to improving lives and discovering possibilities by providing the highest quality continuum of behavioral health care, creating a center of excellence for all individuals seeking mental health, substance use, or developmental services. And then my internship is specifically at the Crisis Center. So this is the program overview. Basically, mobile crisis intervention services and pre-admission screenings to see if someone needs further treatment because they are an imminent risk of harm to self, others, or the community. And down here it shows, or it says that all the evaluations and where we can do those at. The client that I am going to discuss today is a 42-year-old female. I put that her family situation is complicated, and while I discuss this client more in depth, you will kind of see why. Her family is very supportive, but she doesn't believe so. She is disabled. She's never been married. White, not Hispanic. There's not any family history that we're aware of. And right now she does reside in the community with her grandmother and active with Highlands outpatient services. And those services include case management, psych services, and medication management. Okay, for the history of problems, she has a current diagnosis of schizophrenia unspecified, although there is a discussion about a possible dissociative identity disorder diagnosis. She's been receiving mental health treatment at HCS since 2017. And currently she is in case management, psych services, outpatient therapy, and medication management. She does have a severe childhood and adult trauma history. Her first hospitalization was in 2008. Since then, she has been hospitalized numerous times throughout the state of Virginia and one time in Pennsylvania that we're aware of. And recently, I believe it was back in December, she was hospitalized in Washington, D.C. She was hospitalized at Southwest Virginia Mental Health Institution, which is the state hospital in Marion, for 2.5 years, and recently released in September of 2023. So since September, Highlands Crisis Services has had numerous interactions with her, with the most recent being on 3/6/2024. She's enrolled in, like I said, case management, psych, outpatient therapy, and medication management. And her current life stressors is maintaining in the community. Due to her mental health conditions, she does not have a POA or a guardian, which would help her maintain, but her family is unwilling to take on this role. And this is when her mental health becomes a little tricky, because at the time of her last assessment, she does switch from different personalities. So when she was brought in to the crisis center, she was one person, and she does have names for these people. She'll identify as this person when she speaks to someone, and then she fell asleep at the crisis center because she enrolled in our 23-hour services. And when she woke up, she was someone else. And this person did not identify with the person before. She had no she did not remember coming into the crisis center. She wanted to leave immediately, but on a professional standpoint, the same concerns for her physical body that we had when she initially got there required us to get an ECO because she did want to leave. So we needed to keep her there to complete a pre-screening assessment. And then unfortunately, just due to the main concerns of when she initially came in, she did meet criteria for a TDO, and I'll get into that a little bit more. It's a very tricky case, and like I said, we'll discuss that a little bit more throughout this presentation. So the date of the last pre-screening assessment was on 3/6 of this year, but she does have ongoing outpatient services through HCS. This is the last time that I had contact with her, though. Like I had said, she was enrolled in the Anchor program, which is a 23-hour crisis stabilization program at 5 a.m. But when she was there, she did think that, she came in, she was having suicidal ideation. She goes on to say that she did think about taking pills and, ending her life. So that's why they initially enrolled her. She did fall asleep while she was there, and she switched to a different person. She has a history of switching to different people. And this is something that the Community Service Board, HCS, is just having a hard time navigating. So like I said, when she first got there, she switched from another personality. When we did the pre-screening assessment, it was after she woke up, so she had already switched. And this identity, let's just call her Mary. We do say the other Marys, and sometimes she is aware of that. She knows that there are other personalities, but sometimes she's not, and she is a whole new person, and let's just call the whole new person Sarah. And when she switches to Sarah, Sarah has no recollection of the other Marys. Sarah has her own trauma. Sarah has her own childhood trauma that she works through. She has flashbacks, and most of the flashbacks that Sarah has is like flashbacks of her being in a war and seeing a lot of people dying around her, and it's just, I spoke to her on the phone one time when she was Sarah, and she was very distraught over these flashbacks that she was having about the war that she was in when she was a child as Sarah. But when she is the other Marys, she kind of has some knowledge of the other people around her, if that makes any sense. The reason that's one of the reasons that the company is considering the DID diagnosis. The reason that we've kept her as a having the schizophrenic diagnosis as well is because she thinks that other people switch. So while we were doing the assessment, she thought that I was switching from different people, and the coworker that I had with me was switching to different people. Especially if you leave the room and come back. She usually shuts down. She thinks that you're a completely different person. But if you stay with her in the same room, she thinks that you're switching, but she's still open to talk to you. Okay, so anyway, um, at the time of this assessment, she was pre-screened due to the original report of her suicidal ideation with a plan of possibly overdosing on the pills. She woke up, she switched. The new Mary that she was identifying as denied being the person from before and stated she did not have any knowledge prior. She's not suicidal, she's not homicidal, she's not anything. She wants to go home. She did not remember coming to the crisis center. And due to this, she was placed under an ECO because she was attempting to leave after making, the drastic statements of wanting to harm herself when she initially arrived. She does not understand that the same physical body that came to the crisis center is who she is now, and that's why we were concerned, even though she was not identifying as that person. Whenever we did the pre-screen, she thinks, she made the statement like that was one of the other ladies, that was one of the other girls, that wasn't me. But she was disoriented to person, place, and time. She did lack capacity. But it's heartbreaking because whenever you talk to her, she's like, it's not fair to me because I was not the one that said it. It was the other woman that said it. Yes, we all come here together. Yes, we all do this, but it was the other person that said it. And so she has a hard time understanding why we're concerned. Because it wasn't her identity at the time of the assessment that said it. Moving on to the client-intern relationship. The assessment of trust. She appears to be very open and honest with the intern and the clinician who completed the assessment. She normally does have a positive relationship with the crisis center and will normally reach out and speak to someone if she is escalated, if she wants to talk to someone, if she just needs help. The factors contributing to the positive professional relationship. Like I said, she has an ongoing relationship with HCS and will reach out. Rapport was able to be developed pretty quickly due to this, and she already felt comfortable speaking with the crisis worker and me, the intern. But unfortunately, a hindrance to this professional relationship is the ongoing switching. So there is one person, one identity that she has, and this person does not like crisis. She cusses us. She does not want to work with us. She hates us. All the above. She gets very escalated, and she's hard to work with. But when she's everybody else within her system, she's usually pretty open to us, and she likes to work with us, and she reaches out for help. So that's the hindrance, is just working with all the different Marys, all the different identities, and just knowing which one we're working with that day. All right, moving on to knowledge utilization for engagement, assessment, planning, and intervention. I have put the Virginia state law on here for adult cases. The respondent is unwilling to volunteer or incapable of volunteering for hospitalization or treatment, has a mental illness and is in need of hospitalization or treatment, and that there exists a substantial likelihood that, as a result of the mental illness, the respondent will, in the near future, cause serious physical harm to self or others, as evidenced by recent behavior causing, attempting, or threatening harm, and other relevant information, if any, or suffer serious harm due to respondent's lack. So this is the law in the state of Virginia that allows for a community service board to obtain a temporary detention order, sending them to a hospital if they are unwilling. If they are sent to a hospital under a TDO, they have to stay for at least 72 hours. After that 72-hour mark, they will have a court hearing with a special justice. They get an attorney. There is an independent evaluator at the hospital that does their own evaluation, and then there's the treatment team at the hospital. At that court hearing, they will determine if this person needs further treatment past those initial 72 hours, or if they're able to return to the community in a safe way. So after meeting with Mary for the last assessment, she did reach criteria for hospitalization under a temporary detention order. So for the history of interventions, consumer has a known history of reaching out for help, like I had discussed earlier, when she does not feel safe or she wants to speak to someone. Most of the times, her delusions, paranoia, and switching is considered baseline for her. So if she calls into the crisis center and she is, talking about switching, talking about her grandmother switching, those sorts of things, we will just kind of talk her off the ledge that she's on, just kind of de-escalate her, talk her through her coping skills, and she's like, oh, I feel so much better. By the end of the call, she does feel better. She moves on. That's just who she is. It's just baseline for her. Unfortunately, she does feel better by the end of the call. She normally states this, and then the call ended. But sometimes, if she is unable to be talked down, or she does make concerning statements that are not what Highlands would consider baseline for her, if she is having delusions, there was a time before Christmas she was having delusions that she had pinworms on her and in her, and she was losing her mind with that. If she ever makes a statement that somebody is switching, she just can't be talked down. She thinks that these people are after her. She thinks that she wants to go after these people. If she makes any concerning statement that is not able to be talked off the ledge or not baseline, most of the time we will send our Marcus Alert team out to her. Our Marcus Alert team is a crisis clinician that teams up with a law enforcement officer, and they will respond in the community to wherever the person is. They are aware throughout the county, and dispatch will get them involved, and we can request for them to go out as well. So if she is unable to be talked off that ledge, if she's just not able to be talked down, if she needs more help than a phone call can provide, we will ask Marcus Alert to go meet with her. And then that clinician that goes out with her can see if she needs to be brought in to the crisis center or if she needs further intervention. Her family is very aware of this switching and her baseline, and sometimes they have even called if she is just not at baseline or if they are concerned. So my practice wisdom derived from past experiences, I do have experience with a TDO, emergency custody order, and pre-screening clients. I do have a past knowledge of her. I have had several chances to meet with her and talk to her, and she is normally an ongoing conversation within the crisis department just because her case is so unique, and we are sometimes at a loss on how to manage her. And unfortunately, it is very sad, and I could not imagine being in her shoes. But we do have a lot of knowledge about this specific client, and we try to work with her as best as we can. My personal life experience and insight. I do not have a lot of personal experiences or insight with this population or with these specific issues. So I don't have any knowledge going into working with her that I could use from a personal place, but I feel like that's okay, and we continue to move forward with her and meet her where she's at and get her the best treatment that she needs. All right, so for intervention and plan, so at the time of this specific incident on March 6th, she was hospitalized under a temporary detention order. She went to a private hospital. She did not go back to state. At the time of her court hearing, after those 72 hours, she was committed for up to 30 days, although she was discharged after 7 days, back to her mom's house. She has continued contacting ES, and I say ES, that's emergency services. That's where my internship is at, in the crisis services unit of HCS. But she has agreed to continue participating in outpatient treatment. There has been a community-wide conversation about meeting her needs and this diagnosis of DID and what that treatment will look like if we did move forward with that diagnosis. She does follow up with outpatient services. I believe she has daily contact with her case manager to help her maintain and just monitor her mental health symptoms. And like I said, if she continues being baseline, the case manager has a good knowledge of that and will report her to crisis services if she feels like she is not at baseline. So there are questions, and this is another form of conversation that's had throughout the Highlands, is possibly obtaining a POA for her or group home placement, because unfortunately she has had a hard time remaining in the community at baseline. Like, her baseline is getting to the point where she does not have capacity even at baseline. So sometimes she will come in to the crisis center, or she will be working with her treatment team. She will sign releases, she'll sign consent to treat, she'll sign all the documents, she'll provide us all this information, and then she'll switch to a different Mary or a different person. And she's like, I don't know who this Mary is that signed these papers, but it was not me. I do not want to keep taking my medicine. I do not want to keep doing these services. I don't want to keep meeting with you people. I want to go home. I want to live my best life alone at home. So she makes the decisions for herself. She's her own person. And once she keeps switching, she does not make the best decisions for her. She'll sign herself out of services. There was one time she tried to discontinue her, what's the word that I'm thinking of? Like, her disability checks and her insurance, because she did not believe that that was the person that she was. She will go, recently she went to Washington, D.C. because that person that she identified with wanted to go to Washington, D.C. Unfortunately, she did get hospitalized in Washington, D.C., and she was sent back to this area. So she's just not making the best decisions for her, because she can't maintain an identity. She does maintain better, though, when she's alone. When she first got home from the state hospital in September, Highlands has a department called Permanent Support Housing, and they will help people. If they're active with Highlands, they will keep them in a hotel and then keep them in a hotel until they're able to get them a permanent housing. She was doing that. She was in a hotel. She was maintaining pretty well. She was alone there for a couple of months. I mean, she did call crisis services. She was able to be talked down a lot. We didn't see her for a while. I would say a while. It was probably like a month of her maintaining by herself. There's one specific Mary that thinks her past trauma is a lot of like sex trafficking and sexual abuse that she endured. And if she is that Mary, she thinks that the people that trafficked her are out to get her. And that was a lot of what was going on when she was at the hotel, was that those people were out to get her. But she never wanted to go back and harm them. She never wanted to hurt the people that were after her. She just wanted to be safe. Until December of last year, when she thought that she had pinworms. When she thought that she had pinworms, she thought that she was being overrun with pinworms, and this is when the schizophrenic diagnosis comes in. She got to the point where she was wiping her hands and her face with Lysol wipes, continuously cleaning with household cleaners in her hotel room, and the case manager went to go pick her up to get to take her to Walmart to get a few things, and she had bought numerous bottles of bleach. And our concern, that's when they reported it to crisis and brought her to crisis. And our concern with that was she was already using the household chemicals and cleaners on herself. We were concerned that she was going to start using the bleach in her food and possibly ingesting it to help her get rid of the pinworms that she thought she had. When I saw her at this point, this is the first time I had ever seen tactile hallucinations. She used an entire box of tissues while we were talking with her because she thought the pinworms were crawling on her. She continuously wiped her face, wiped her hands, would show us the tissue. Don't you see this? Why aren't you all afraid? They're going to get you. Don't you see all these worms that are on me? And she had an actual rash. She was broken out. Her hands were cracked because of the continuously washing and cleaning and all of that. So at this point, it was decided she was not able to maintain in this permanent support housing, and she had to live with a family member, and she did go live with her grandmother. So due to all of this, the Community Service Board is wanting to possibly get her a power of attorney to make her decisions for her. Her family's not willing to do this, but there are some services in this area that will take on that role, even though they're not related. I believe Jewish Family Ministries is one of them, and there's another one, and I can't remember the name of it. But they are willing to take on the role of the power of attorney, even though the family will not. All right, moving on to further discussion. I knew that this client has a lot of history and a lot of just mental health needs that unfortunately are not being met at this time, even though the Community Service Board is really trying. It's just hard to meet someone's needs at this point. We're doing as much as we can. And the possible ethical considerations that I can think of is, like I had said earlier, she switches from one person to the other. And so that's when confidentiality and consent to treat comes into hand. Because if she signs a consent to treat form before seeing us, and then she revokes her services with case management and outpatient and medication management, She does lapse on her medication. She lapse on her treatment. Um, Confidentiality is another issue that we have with her. Just like the last time we saw her, she went to sleep, woke up a different person. So when we asked her about the person that initially came in, she knew that it was another person, but she kept saying, that's against HIPAA. I can't discuss their needs with you. They're not here. There's no way for me to discuss it. They're not giving me consent to discuss it with you. So on her end, confidentiality is a big thing. On the crisis department end, I mean, we are able to discuss within the department and within the community service board her needs because she is a consumer. But it can get tricky, especially like if her family's there. She has provided us a release of information to talk to her mom, and then she, as the person she is identifying with at that time, revokes it on the spot. We can't talk to her mom anymore, even though we have this form that she signed 2 days ago saying that we could. So it's very tricky. It's a hard road to navigate, but we do the best we can. So lessons that I've learned while working with this client, it has promoted a lot of discussion about the DSM, a more accurate diagnosis, and it's promoted the discussion within the community service board to meet the client's needs on an outpatient basis. They started discussing the DID possibility, as there are many inconsistencies in symptomology that felt like it could be more applicable. It was our thought that she could possibly be experiencing the co-occurrence of both disorders of DID and schizophrenia, but no one has noticed the DID because of the history of psychosis and automatically attributing it to the delusions. So nobody's really considered DID as a diagnosis until now. Although she was placed at the state hospital for a couple years, the ongoing thought of her being other personalities has not changed, and that is considered baseline, even though she has experienced several other delusions in the meantime. We did discuss with her identifying with which person she is with identifying as a color. So if she comes in there and she's like, hi, my name is Mary, and we're like, are you Mary Pink? Are you Mary Orange? It could kind of give Highlands a better understanding of which Mary we're working with that day. The only difficult thing about that is not each identity in the system will understand. So they'll be like, what are you talking about? I don't know what you're talking about. And then the other identity will understand what we are talking about and will identify as a person. So we've discussed that throughout her treatment team. They are aware of the color guide as well, and we'll use it to our best ability. I know that you all will probably have a lot of thoughts and opinions and questions. But a question that I have is, to your all's knowledge, are you aware of like APS? Could they assist with obtaining a POA for her? Could they assist in this situation at all? Like, I know that APS has been involved before and not really done a whole lot, but if we mentioned the possibility of POA, is that something that they could obtain for her? And could the treatment of DID be an option to see if it will help? I know that she has been continuously treated for schizophrenia, and that treatment usually does help those delusions. She did have the pinworms a couple months ago, but other than that, she doesn't have a lot of ongoing delusions. Is there a treatment for DID that maybe could help her maintain as one person and continue treatment as needed, that you all have had experience with or that you all know? All right, thank you for listening. Hopefully I can answer some more questions that you all have in the class that we have coming up. And just email me or message me if you have any other thoughts or questions in the meantime. Thanks.